Welcome everyone to this webinar. My name's Karen Mitchell and I'm a consultant chemical pathologist, and I'm currently the chair of the informatics group at the college. And today's webinar is on the future of AI in pathology, a guided tour. The webinar will run for approximately an hour. We have a presentation of about 45 minutes, and then we'll have a short question and answer session afterwards. To ask a question, please use the Q&A function at the bottom of the screen. Those of you attending can self-credit for 1 CPD point for today's webinar, and this webinar is being recorded. I'd like to introduce our speaker, Owen Johnson, who is an associate professor at the School of Computer Science in Leeds, who's kindly going to take us through a guided tour of AI. I will hand over to you, Owen.
Thanks, Karen. And hi, everyone. It's fantastic to be talking to you today. The background to this is that I'm also on the Royal College of Pathologists informatics group with Karen, and I think I volunteered to do this talk. It's quite ambitious, a guided tour of AI in 45 minutes. I'm pitching this at relative novices, so anyone who works in pathology who is of AI curious. I suspect there will be some excellent people doing some excellent AI work already, and fantastic that you're here on the call or that you're watching the recording. I'm part of the reason I volunteered to do this. I kind of want to hear from you. So please do raise comments and questions in the chat. We'll get to those at the end, but I'm really keen to hear from you and to kind of use this as a beginning of a conversation rather than just a simple briefing. So as Karen said, I'll try and talk for about 45 minutes, and then we'll finish off with a bit of discussion and Q&As and next steps, so finishing bang on 2 o'clock. I would like you to think after this session, how could the Royal College support its members adopting and adapting to AI? And also just think about yourselves and how you might support each other, what support you might want from each other. So we'll come back to that at the end, but that's a kind of reflection homework for you, and maybe have a think of that as I talk. So there's a lot to cover in a guided tour. And I think the starting point is probably just separate pathologists and what you might want to use AI for to everyone else who might want to use pathology results, or even might want to actually use more pathology services because of AI. So I'll try and cover both and jump backwards and forwards a bit, but I'll come back to this slide at the end and just sort of try and draw this conversation together. So just briefly, from a workflow management point of view, some pathology labs are using automation and robots. There are things like AI agents and scheduling tools. So from workflow management, that's one type of AI. Very popular and in the press a lot is the idea of ambient scribing, medical notes. I will come back to that and some of the challenges involved in that. There's a kind of productivity tool with kind of ChatGPT. You might find equipment that you've got has got embedded AI within it. And the interesting bit to me is whether we use AI to augment or automate or safety check decision making. One area of huge growth that we'll come back to is digital pathology and images. I guess most of the people on the call will be not histopathologists, but if they're histopathologists, it's fantastic. Histopathology is doing amazing things with images. In the other pathology disciplines, it may be a little bit more interesting to try and figure out how AI might help. Okay, right, so let's dive in. First thing then, about AI, what and where is it? And if I have to start at the beginning with Alan Turing and the Turing test. So this is the Benedict Cumberbatch film. The Turing defined artificial intelligence as something that could mimic cognitive functions, and he posed this test of is it smart enough to be able to be indistinguishable from that of a human? Now, I think most of you, if you've played with ChatGPT, you can tell it's an AI because it's smarter than a human. So we've gone way past the Turing test. Now, the easiest way to tell AI is because it's just a little bit too good. Um, that's my starting point. My other favourite starting point is Isaac Asimov, although if you're fans of science fiction, there's lots of great ones to choose. As Asimov wrote I, Robot and a whole load of robots books, and quite a few of those are movies. What I wanted to just pick on was these pictures. If you have a look at the I, Robot covers in the middle, this was one of the original covers, and this is kind of slightly more modern cover. The nature of robots is something that might be super friendly, or they might kill everyone. And if you love sci-fi movies, there's always that sort of tension between will they kill everyone or are they our best friend? Great fun in the movies. However, sadly, that concept leaps into AI. So many people associate AI as robots, and they also think in the same binary way of it's either going to kill us all or it's going to make our lives wonderful. And so my starting point is that we need to get beyond the kind of public bipolar ideas about AI and robots and just get down to some sort of common sensible ground in the middle. So here's some opening thoughts. You might share some of these yourselves. You might have heard these expressed. So AI is a robot. AI is just hype. It could be a cuddly and amusing best friend, or it's going to kill us. It could make all our jobs and lives much easier, or it could make us redundant. White collar workers, there's a lot of talk about white collar workers losing their jobs or companies cutting their jobs because AI is replacing them. There's some talk, Microsoft were talking about an AI doctor that can be smarter than ordinary doctors. So what about pathologists? Is AI coming for our jobs? I love this quote, and I'll reveal where it came from. But you might be at this point in your life where I'm too old to worry about it because I'm going to be retired. And the second bit of this quote, I think, was kind of interesting. Ultimately, I believe it will be the end of mankind, but from an artistic point of view, it will do amazing things. This was a quote from Gary Newman. So if you know who Gary Newman was, or remember his music, then you are old enough to retire. So good luck. But I like the idea that it's going to do some artistically interesting things. Okay, so let's try and guide it all. Let's try and debunk AI a little bit. Just get down to key things. So here's my framework for thinking about AI, and I'm trying to kind of marry that order versus chaos, good versus bad. Where do we sit in all of this? So this yin yang symbol is the idea of two opposing forces that together are always in perpetual motion and therefore always in harmony, and that's life. On the left-hand side, in the chaos corner, I have AI-generated text, AI-generated images, deep learning, very unstructured, and quite chaotic in the way it works and does amazing things. On the forces of order, on the right-hand side, AI as a serious medical device with transparent algorithms and explainable and responsible results, which uses curated and well-structured data. And that ultimately should result in controlled systems. So we need to talk about both of these because we may well want to be on the right-hand side talking about medical devices, but there are a lot of other tools out there that are in the public domain, which have captured public imagination. So I'm going to cover both sides, but I want to kind of give a sense that these things fit together and in a dynamic and ever-changing way. So next, I want to talk about hype. This, if you've never come across it, is a Gartner hype cycle. Closest, most up-to-date one I can get is from June 2024. They charge a lot for these, but this one's free on one of their LinkedIn posts. What they talk about is a hype cycle where anything goes from an innovation trigger up to a peak of inflated expectations, down into a trough of disillusionment, up on a slope of enlightenment and eventually on a plateau of productivity. And the way Gartner do this, which is very nice, I really like it, is that they have different coloured dots. And the dots, as you can see from the index at the top, move at different speeds. So I wouldn't spend too long analysing this one so much as the idea that Gartner are producing hype cycles regularly, well worth following. Artificial general intelligence is the one that might be behind the robots that might kill us all. That triangle means it's over 10 years away from reaching the plateau of productivity. So it's coming up to being hyped. Okay, so we've dealt with hype. I also want to kind of touch back on the legacy of this. So first ever AI in medicine, weirdly for me, because I'm based at Leeds University, and weirdly it was Leeds University that built this. It was a tool for diagnosing acute abdominal pain, which used naive Bayes predictors based on symptoms and outperformed junior doctors, even in 1972. Didn't outperform consultants, which is very relieving, I'm sure. Actual users, though, none. It never got adopted. So even though UK and Leeds was the first place ever to invent medical AI, we're still 50 years later not seeing it in widespread use. So some of the understanding about why AI isn't being used in medicine is kind of important. I'll come back to. Okay, what I'd like to do, and I apologize, this is a little technical bit. If you, at any point, if you're watching the recording, you want to fast forward this bit, feel free. But I think I can explain to non-technical people enough about how AI works in 10 minutes. Fingers crossed. So you're all using things like Google Maps, I guess. And so you're users of AI without really thinking about it. So here's the kind of way Google Maps would work is to take some input, run through some algorithms and produce an output, which in this case might be a route map with some recommended driving route and pictures of congestion. So in this case, AI has been used as a decision support. It's providing us as humans with information that could help us plan our journey, in this case. It could go further, couldn't it? And it could start driving the car. You've probably heard about driverless cars. It could be starting to make decisions and automate those. But look, we tend to prefer AI that just gives us information for us to make decisions. So how it works, well, behind the scenes is a huge amount of data that's being mapped and correlated based on rules and heuristics, possibly a little bit of randomization in there as well. And the secret to Google Maps, the reason that it knows that the road is red right now, or amber, is because it's got lots of other phones going along the road. So you're actually, as you're using your Android phone or your iPhone, you're actually passing your location data back up to Google or Apple, and they're using that to help identify whether roads are busy or not. So they can see how many smartphones are traveling at 25 miles an hour. So this is kind of a general way AI works. It needs very, very large amounts of data. It needs to bring that into huge big databases and then mash that through a range of algorithms to produce something that's useful. So that's what we call artificial narrow intelligence. It's got a particular job, particular function. It can do it very well most of the time. Okay, so I'm hoping that you're happy with that as a simple view of how AI works. So for summarize, it's the data plus an algorithm. We use algorithms to support decision making, and we use data to train an algorithm. Sometimes it's called a model rather than an algorithm. You see or hear both words in discussions. So the way AI tends to do prediction, tends to be used for prediction. Where it is, we talk about things like true positives, false negatives, and true negatives, similar to pathology. There are a range of more complex measures for evaluating the success of an AI. But in essence, it's trying to guess one or more things, and then we need to know how many of those it got right or wrong. So the reason I'm showing you this is not to try and teach you how to do AI, but because the care pathway implications of false positives and false negatives in particular are really quite dangerous. So when we use AI to do something in clinical care, we need to think about what happens to people that have had a false positive or negative. And I guess you can think of the same as if your a pathology result was incorrect for some reason. In some ways, a false negative is probably more dangerous because that kind of implies very likely harm. False positives might involve extra treatment, extra diagnosis, which hopefully would be spotted. So when AI is used to do decision support, we need to think of the consequences for patients for that decision, for getting it wrong. So pulling this back a little bit then, if we think of AI as being used to make a diagnostic decision, it might be as simple as a yes or no, okay or not okay. Behind the scenes or underneath the stack is an algorithm, data, and then a whole load of technical infrastructure. And that technical infrastructure is what's making this AI system work. So let me give you a few other types of AI, and I'm broadly generalizing, so my colleagues would be horrified if I'm making it this simple. Artificial neural nets, there are many, many different flavors of these, and this field is moving very quickly. They're all basically variations on old-fashioned pattern matching, which on the left-hand side you can see is you take a number of different objects of different sorts, and you train based on a training set. And then once you've trained enough, you then test it to see against the test set whether it's working or not accurately or not. So the basic problem is usually some kind of pattern matching that's trained on a gold standard of results. The neural network bit is that modern AI is increasingly based on networks of pseudoneurons that look like or mimic the ideas behind a human brain, where you have a whole load of different layers of neurons that will fire or not fire based on a reward mechanism. So reward if you get it right, basically. So you run thousands and thousands of times through neural networks to train an AI model, which can then be used for diagnosis. So in this case, this is a lung X-ray. Well, the question is this TB? And the output is no. Well, probably not. So that's the image analytics in digital pathology, hugely fast-growing area, and basically it'll work along smarter and smarter versions of this model. What we can do is a little bit clever, and actually the AAP Help algorithm that was developed in Leeds did this in 1972. What we did in the abdominal pain algorithm was to feed back whether it got the right answer or not. So what we can do is say, well, actually, in this case, the algorithm was actually correct. So I'll add that image and the result back into the training set. The result being that my training set is going to get bigger and bigger over time with correct answers. And that allows me to then retrain the model. So if we can build a learning loop where the outputs of AI are informed by whether it got it right or wrong, we can build AI that should get smarter over time. So that's the kind of learning loop in AI. So I'm going to just segue across to robots because I think I can explain robots reasonably quickly by simply saying robots are just hardware. Just hardware. Laptop is hardware, a robot is hardware. Robot's got more moving parts. It's got more sensors and it's got more effectors. It can do more action. Might be able to do voice and data. Behind the robot then is the software, and that will be the control logic and a whole load of AI models. So the AI models we might build for any other application might also be similar to the ones that go into robots. So machine vision is a good example of that. The other thing that's worth bearing in mind with robots, which is in the sci-fi movies where they're all really crazy and kill everyone, is it depends on who's the owner, and it depends on links through the internet to anything, potentially even to other robots. They can start acting as autonomous agents together. So the networking element of robots is relevant too. So it's doing that pattern matching neural network approach, but I've got colleagues who work in robotics, and the kind of problems they're trying to solve is how you turn a tap on with your hand. You know, you turn it on, turn it one way, then turn it the other, turn it backwards and forwards until you get the right amount of flow, and then you stop. So robots have a kind of very tight feedback loops in order to kind of be able to manipulate things. Okay, we're doing well. Now, generative AI, which is the kind of ChatGPT, large language models. This is the thing that's probably captured most people's imagination. And I'm guessing most of you have used this at some point, or at least you've certainly read stuff that's been written by generative AI. So the typical application would be, can you write a report on blah, blah. And you'll get some wonderfully excellent verbose text with some hallucinated information, but it all sounds very plausible. I've highlighted the word hallucinated because one of the big challenges with generative AI is you don't know whether it's correct or not, and it has a temptation to make up facts which seem very credible. So I liken ChatGPT to somebody you meet in a pub. It all sounds very plausible, but you really need to check and verify. So the way it works, it basically can draw on the entirety of all human knowledge through the internet. They'll train on a subset of that, but you can train ChatGPT on vast amounts of data, basically applying the same neural network approach that we saw. But also the way it works is by a process of tokenization and matching of tokens behind the scenes. I hope that means you now have a grasp on how ChatGPT works. There's some R buts, so let me just run through the R buts. I think these are particularly important for those of us that are kind of medics, scientists, and professionals. We need to be aware of what can go wrong here. So the interesting thing with generative AI is it can actually it looks like it might start killing itself. Let me explain. Imagine that you got all this wonderful text and thought, oh, I'll paste that back into the internet. Now, by pasting that text back into the internet, you're putting it back into the training set for the next generation or next iteration of large language models. So what's likely to happen over time as you put more and more AI-generated text back onto the internet is that we're actually creating garbage back on our source material. So we're kind of polluting the internet with AI-generated content. It's not just me saying that. There's a really nice paper in Nature which describes how it's called AI model collapse. There is a fear that AI models will effectively collapse by recursively using their own generated data. So kind of interesting discussion about what's going to happen to the future of the internet now, the future of knowledge, if everyone uses generative AI to kind of create fake knowledge. So that's problem number one. Problem number one, hallucination. Problem number two, we're eating our own garbage. Problem number three, bias in AI, sadly, is inevitable because sadly our history is founded on bias and inequality. So you can go back in time and think about slavery, for example. And our history is riddled with bias and inequality. Hopefully most of that is gradually being addressed, but the reality is that all of our data that we use to train AI on is reflecting bias and inequality in the way that it's structured. So if we train AI on historical data, it's going to learn our history and is at risk of reproducing it, which might mean it favors white middle class men, because historically maybe the healthcare service has done that. Certainly clinical trials did back in the day. There are some real issues with bias. There are a whole range of ways of thinking about and addressing that, but these are not automated. So AI that's just blindly built may well blindly include bias. AI needs to be very carefully built in order to understand all these different sources of bias in the model life cycle. So next thing to bear in mind, and I really hope you're aware of this and clinical colleagues are aware of this, is that the data governance with AI is not necessarily as obvious as it might be. Obviously, when we work within a regulated healthcare environment, such as the NHS, we have a firewall around us, and patient data, and in fact, data about any person, including colleagues, should not be going outside of that regulated environment. So this ought to be fairly obvious. However, there are leaks at every level to the outside world. And you can think of the outside world as not the NHS, but you can think of it as America or China or outside European Union, but even just outside the hospital walls. So outside of the NHS is not a regulated environment. There are allegedly 3,000 unregulated apps in use in the NHS. I suspect it's much higher. So that's potentially patient data and colleague data and NHS confidential data being used outside of the NHS environments. Similarly, a lot of the algorithms, like particularly ChatGPT, but a lot of the ambient voice technology, things like translation technology, are using cloud solutions which are not in a regulated environment and really should not be used for any kind of identifiable patient data. And so the kind of warning is that when you're using technology, particular AI, you need to be aware of where it's sat and where the data is sat, because the data should not be going outside of the NHS. So that's hopefully a few health warnings. Let's move on to AI for pathology. So if you were zooming forwards, this is a place to pause and come back down to normal 1 speed. The 10-year plan is out, and I guess many of you are sort of reading it and digesting it. I think we've probably all got our heads around the 3 radical shifts. And shift number 2 from analog to digital, obviously is the area I'm particularly interested in, but worth thinking about. Make the move from bricks to clicks, doctor in their pocket in the form of the NHS app. So they're banking a lot on the NHS app, and we kind of need to understand that and how that might affect pathology. This picture, this is Wes Streeting when he was in Leeds about a month ago. I'm actually in this picture. That's the blurry picture. It's just me there. But more important than me is Lawrence Talon, who's chief exec of MHRA, and one of the things that they announced on the visit was the MHRA are locating a new digital hub in Leeds, 30 new people in a new function to support digital technology, digital adoption in the NHS from a regulatory perspective. So more on the regulatory side later. Okay, so here's the NHS app. I guess you may have it. You can have a look at the kind of type of information. This is basically the type of information that's on the NHS app right now. Whether this is really usable to the average patient, I don't know. I suspect the average patient will do what I did, which is copy and paste that and put it into ChatGPT. And now I'm getting a little bit of worry about the serum cholesterol. So I'm getting some ChatGPT advice, but what I've done is I've done exactly what I shouldn't have done, because I've broken all the data governance. I've just taken confidential patient data and put it in an unregulated environment. Fortunately, it was my own data, so I think I'm allowed to do that as a patient. But patients will be doing this, and we have to worry about the fact that ChatGPT and the other solutions might well hallucinate. So it would be better if the NHS app was able to work with pathology data The other thing that's interesting is I then asked it, how often should I get my cholesterol tested? And it's suggesting here every 3 to 6 months if I'm making lifestyle changes to improve my cholesterol. So if I start eating loads of salad, maybe I should be getting my cholesterol tested every 3 to 6 months. So the reason I'm showing you this is because effectively what the AI is doing is recommending more testing. So the volume of testing for pathology labs might go up because AI tools are saying get more tests done. And they may be specifying particular tests which may or may not be appropriate depending on whether it's hallucinating or not. So getting the app under control becomes really important. So it's a good thing that we're expanding the app, but there are risks here. And as I hope you can see that there are challenges for pathology in terms of the data formatting that we might do, and in terms of the way data might be interpreted down the line. Okay, so come back. I've kind of done a whistle-stop tour of what AI is. And I've talked a little bit about robots and agents and a little bit about ambient scribing and medical notes, at least the risk, which is that you could be putting patient data into the unregulated environments. So I want to just focus on some of these use cases and with some examples now. So good news, in the UK, we are one of the leading places in the world for digital pathology in histopathology. So National Pathology Imaging Cooperative, which you may have heard of, NPIC, is a leading centre for looking at very, very high resolution tissues, slices as high resolution images, and indeed applying lots of AI. So I run a centre for PhD training in AI. 3 of my recent PhD graduates have all just gone to work there and were working on research based on histopathology. So in image analytics, I think we should be proud of UK leadership in this space. The other thing I mentioned about the MHRA is worth coming back to. Like it or not, the UK has decided on an independent regulatory strategy to the EU. The rationale is that we can be more agile and more faster. The reality is we're going to see, aren't we? But so MHRA has become, or is responsible for regulating medical devices and in vitro diagnostic devices. And AI can be one or either or both or not, depending on the risk of impact to the patient. So if you are using an AI within a regulated environment and you're using AI to do a structured task, it should have been registered, and it should be registered as a medical device or IVD. So if you're using one that's not registered as either of those, you, I think, have the responsibility as a professional to think about whether that has a risk of impact to patients and not be using it if, in your view, it could be classified as a medical device or IVD. There is some really good guidance from NHS England, and that will, I'm sure, evolve. So I would keep looking at it. And there are ISO standards for how to do this well and properly. I've put a few there. The MHRA's future regulation of medical devices actually started a month ago, 16th of June. So whenever we're talking about AI within clinical contexts, I would say look for regulation, look for certification as a medical device. Okay, there is the NPIC team have created a register of AI-based digital pathology tools and a nice paper to go with it, which I've linked at the bottom. So I'm hoping that will build up. So one of the things we've got to think about is as we adopt tools within pathology, how do we pass information about them, the safety, the efficacy? How do we work together as a community and hopefully through the Royal College to think about sharing and using tools, making sure that we're using them safely and wisely. So I wanted to just give a couple of little examples of work that I'm aware of or been involved in. There is a lot of work on image analytics, and for 20 years really. Some of the stuff is 20 years old. This is kind of marking up an image with color to show different types of tissue. Typically, sadly, a lot of the image analytics stuff isn't actually in routine use. It's finding that in America, it's the device vendors, the equipment vendors are upselling with AI processing on the back of their product. Other people are trying to sell AI packages that will take an image, analyze it, and give results back. So in image analytics, is adoption of AI, but maybe not as fast as we would expect or like to see. Pinpoint cancer, which is a really lovely example of using blood tests plus demographics to get early detection of cancer. It's registered as a regulated software IVD, which means it's got UKCA marking as a tool that can be used in triage and stratification. So it's kind of gone through the regulatory loopholes in order to be used as IVD device. I've known these guys for the best part of 12 years, and I followed their journey. It took them a long, long time to get this far. But more about them on this link. And then my last example is Victoria Muglia, who's one of my PhD students. Just to give you a flavour of maybe where current research is at. So Victoria's just been at a medical conference presenting this. We are at the edge of what is known and what is being done. So what Victoria did was take a large amount of patients with prostate cancer and found 4 times as many controls for them, took 31 routinely measured blood analytes, and then graphed them and used a variety of different AI tools to see whether she could find early indicators of prostate cancer. And the results on this bottom left-hand corner, there are some weak signals in some of the AI tools, notably this purple one, that can pick up on weak signals that might indicate an earlier risk of, pancreatic cancer. What we see then about 100 days out from the index date, or the date that those people with cancer were detected, we can see a steep rise. So it looks like within the 100 days before diagnosis, we might have been able to do some early detection. So it's kind of interesting work, because what she's doing, she's taking the routine blood results that you might be coming out of your lab now and seeing if they've got some extra information in them. So we're not commissioning new tests, which is using the historic data that patients have already got. But it does mean that the data that you've already got coming out of your labs is being used by researchers, and therefore needs to be good enough quality that it's kind of suitable for this kind of research. Because Victoria's at the very tip of an iceberg of other researchers and other companies that are doing similar things. Okay, right. So currently in the NHS, we're at relatively simple level of use of AI. The big debate in society, the big fear, is artificial general intelligence, which fingers crossed is at least 10 years away, and probably for quite a lot later. So the big fear of the robots will kill us all is what public are debating, but the reality in the NHS is we're just trying to do simple stuff, risk prediction, some basic decision support, and maybe some black box or explainable AI. So question for you, I think, I'm kind of nearing the end. Question for you guys is, where does AI sit for you? Where does it go? If this is, I've tried to map a pathway of from a healthy population through disease and symptoms to a decision to do a test, take a sample, do a diagnostic test, and then give some treatment if needed. and then see whether we get good or bad outcomes. So that's my kind of pathway. Um, it would be good if we could use AI to reduce diagnostic delay. It would be good if we could use AI to reduce risk. Um, but I think from the patient's point of view, what they're really interested in is what I would call process delay. It's the wait, it's the queuing, the bottlenecks. That's not helped when some people are still using paper. Um, so the kind of question I would be asking for you to think about really is where might AI help on this pathway? There will be people using it at these early stages to say, we think there's a higher risk of disease, therefore we need to do a test. So AI, I think, is going to accelerate demand for more diagnostic tests, which is kind of an interesting question. Is can we cope with all that extra testing? How do we make AI more efficient, or how do we make the processes more efficient? I think I'm going to leave this for debate discussion. I did want to make this point though, that when we talk about AI in the NHS, we also have to understand what the NHS systems look like. I think they look a bit like this. So we're putting AI on top of a technical infrastructure that's a bit cracked, data that's interacting with other information systems, health information systems that are a bit wonky, working practices and care pathways which are very, very different. So AI plonked on top of a crumbling system isn't necessarily going to work too well. So there's a big health warning here. We can't just give people the NHS app and expect the NHS IT system is going to be able to support it. Okay, I've got a few slides here that are kind of busy. These are kind of to take away and keep rather than read everything. Now, this is GE Healthcare's views on AI and pathology, which 1 and 2 are kind of medical reports. We're talking about chatbots, we're talking about generative AI, fine. The one that's important to us, I think, is multimodal models. Multimodal combines text, images, and all the structured data. And for us, then that means that our structured data coming out of our analyzers is input to multimodal AI and might help feed better diagnosis and care. And then I've underlined the last 3 because the last 3 are kind of buts. Hallucination, bias, the fact that it might mimic decisions rather than actually make them. It might look very plausible, but not necessarily correct. And their final point, well, GE Healthcare's final point, integrating it requires careful attention to privacy, regulation, ethical design, and human oversight, which I would hope is fairly nobody's going to disagree with. I won't run through all these, but I think these are maybe worth keeping hold of. There are challenges, and I think I've covered all of these different challenges. I like this infographic generated by Gen AI, and some tests on whether medical AI should be responsible. So I've got 2 things to finish with. Firstly, China. China is moving amazingly fast with AI as a national strategy in everywhere, including healthcare. So this is a world's first AI agent hospital, which was a relief, it's just a simulation. But I know that 16 hospitals in Shanghai don't have triage anymore because it's just a touchscreen. So China is moving very, very fast with AI in healthcare. How do we in the UK respond to that? Do we try and give our patients better healthcare with AI as well, or do we insist that none of that's needed? So I think food for thought about how the rest of the world is adopting AI quickly puts some pressure on us, I think. So if I come back to my framework for thinking about it, the dynamic pressure between this chaotic new AI coming out and putting pressure on us, we're going to push back with order. AI is a medical device. And so the next few years are going to be interesting times as AI, I think, is going to reshape a lot of society, a lot of medicine, but also a lot of pathology. So I think that was it, Karen. I hope I'm being roughly on time. Um, and just kind of finish at that point and then see. Are there any questions in the chat at all, or because we were worried there wouldn't be?
Well, thank you, Owen, for that presentation. And yes, there are plenty of questions for us to get through. Um, I think I'd like to start with my question, which is why do you think that AI is a popular focus in the NHS now? I was quite interested with your hype graph. Do you think is it all hype at the moment?
Goodness, yes. Okay. There is a hope, and it's right through the government strategy. There's a hope that AI is going to save the NHS. And that there's probably more a hope than a strategy. But this the 10-year plan does put meat on that, and so I'm going with it. I'll give them credit for. Um, there is AI has captured the public imagination everywhere else, and I think hopefully in healthcare too. The problem, if I remember my crumbling infrastructure slide, those of you that work in the NHS know how crumbling it is. So I worry that uh, we can't just plonk AI on top of everything else that doesn't work.
Yeah, that's understandable. So we'll try and kind of whiz through some of these. I think some of them obviously were related to various points on your talk, but you were in full flow, so I didn't think it was worthwhile to interrupt you. So we'll start with the first one of how would you ensure quality assurance of AI use in a pathology department?
Gosh, really good question. Thank you. There are international standards for quality management systems. And there are international standards for quality management of AI. And so it's a bit of a trite answer, but my answer would be we should follow the standards. There's a lot of intellectual effort has gone into developing standards for quality management systems. And, I think the danger is where people just reactively go off and use AI thinking they don't need to follow the standards.
Mm-hmm. Okey-doke. So I think there are a couple of questions about sort of training models. So again, I think it's probably similar of would retraining the model with the same data set make it overfit and hence potentially be less generalizable to future applications, and how are we clinically validating? Not sure if that's a similar kind of question.
No, it's a really tough question. It's the Nature paper about model collapse is one extreme, where the whole world would just collapse because we're just training on the data we've generated ourselves. But I think there is a danger that there's this lovely phrase overfitting. An AI that overfits becomes very, very good at working in exactly the environment it's in at
Mm-hmm.
the expense of not being able to cope with change. So overfitting is a dangerous phenomenon that can occur with too effective training, I guess. I don't think that's a good answer other than to say we shouldn't obsess about fitting too well, which is kind of rather strange, isn't it? You actually want an AI algorithm that's not 100% or even 99.9. 95% is probably better because it's less well fitted. And that 5% is the humans in the loop need to be able to understand when the AI's got it wrong
Mm-hmm.
and what to do about that. And so you can imagine someone from an ethnic minority who's got an unusual blood result. And, the fact that they're from an ethnic minority might be important, might not
Mm-hmm.
be, but that's why a professional is needed rather than just a machine.
Mm-hmm. Okay. Um, so yeah, there's obviously some similar questions around clinical validation. I was going to jump down to one. Have you found about completing a clinical safety report for diagnostic AI tools? I don't know whether you've come across anything relating to clinical safety in the use of some
Uh,
of these
no,
tools.
but I did I was weirdly I was on a 3-hour training course on medical device regulation because I thought I need to know about this, and part of the technical file that you need to do in order to get a medical device approved is to build a technical file which includes a detailed clinical evaluation and risk safety model. So the process of going through the regulatory approval should have dealt with all of the risks and, identify all the risks, worked out the mitigation, and followed that through. So I think the regulatory approach is really going to be really helpful for us.
Okay, that's good. There's one about has there been a cost benefit analysis to see how these tools have helped so far? And then from Bernie Crowell, our president, has asked, can the NHS afford AI? So, do you have any comments about the financial implications of AI?
Oh, okay, yeah. Well, let me answer the Bernie question first. AI is dead cheap. It's really cheap. It's just a piece of software. It's not the same as a box or a hardware. So I mean, AI may not be cheap because the suppliers are charging a lot of money for it, but you don't need the best possible AI. You just need some AI. The reason AI costs money is because taking any algorithm through regulatory approval costs minimum £100,000, and therefore whoever did it has got to recover their money, and they've got to. So they can't do AI for free. It costs a chunk of, like a bit like a drug, but without any of the high levels of costs of a drug. So I would say AI in itself, not really expensive. The training of people to be able to use AI well, the infrastructure, everything around AI to be able to do it well costs a lot. And so I might say, if Benny was online, he can't answer, can he? Um, so I might say, can the NHS afford not to do AI? And we're seeing a lot of senior consultants retiring. I don't know how many pathologists and histopathologists and people retiring, but I know that in order for the workforce to be able to cope, they probably need faster, smarter tools to do all the easy bulk lifting stuff, so that as professionals you can do all the hard, intellectually interesting and medically challenging stuff.
Interesting. So, on a related or the other end of the scale note, we've got a question. I'm a first year in histopathology. Will AI replace me in 10 to 20 years? And what things do I need to do to keep myself employable and thriving in this new environment?
Oh gosh, yeah. People might. I don't think so. I think keep doing the degree. Don't panic. I don't think so. I think that the goalposts will move. If you imagine that it becomes 10 times faster to do histopathology, one solution might be to need 10 times fewer histopathologists. The reality is we're just going to order 10 times more histopathology testing. Demand as the ease of using, as AI makes diagnosis and pathology faster, I think our volumes are going to go up. And I think at the moment, one of the issues with histopathology is turnaround time. It takes too long because it's got to wait for a person to look at it. And if you can just automate that for 90% of the people, then the 10% is still going to need a human. So don't quit your course.
Okay, so I can see we're heading towards 2 o'clock. So I think we've got time for a couple more questions. So um, there's one about how do we make sure that AI is safe for, oh, sorry, the NHS app is kind of verifying AI software and just, I guess, the link between that. Um,
Yeah. And so what I understand the plan is with the NHS app is that commercial suppliers will develop plugins that will plug into the NHS app. So it'll be more of a kind of shop window to other applications. But in order for those applications to be allowed to plug in, they should have gone through some quite rigorous and robust validation of their services. And so I think we have to put some faith into the centralization of the NHS app, and that I think is fine. What worries me is that data quality of our underlying systems may be introducing problems that the NHS app people don't understand locally. Certain places might use a different unit of measure and mess up the app.
Okay. And then so we're probably going to run out of time for a lot of these questions, but something obviously close to my field is so the question from we've got online is, you gave an example of AI application in histopathology, which has become very useful. What's your views of other disciplines? And I'll tag on to that. So my view is it's lots of images and pictures. I deal with numbers from biochemistry. What do you think the applications? Obviously, you mentioned the pinpoint project, trial, app, wherever they're considered now. But where do we go with other disciplines within pathology? Do you think there is obviously huge areas for targeting, but is there anything in particular you can focus on?
I think Karen, Karen and I were discussing this earlier. Imaging seems to be wildly successful in kind of blood sciences or virology, for example. Then what's AI going to bring? And AI is going to use the product of the pathology lab, as in the data that comes out. So that definitely we need to think about it as passing that down the pipeline. But how do we use AI within the lab? And I think you can think of it as when do you use pathology? When do you use a pathologist's intelligence? And when you use a pathologist's intelligence, are you basically making the same kind of judgment over the same kind of numbers on a regular basis? So whenever you've got a job which is a bit boring or a bit routine, eyeballing yesterday's numbers, for example, that could have been programmed. That could have been AI. And AI is not going to do it perfectly, but it could have made it faster and smoother and maybe got turnaround times better. So the big thing I think is that we use a very blunt instrument called a reference range. And I just think, we've got to get a bit smarter than that. So reference range for an entire population isn't necessarily as smart as a personalized reference range or a reference range for people of this particular demographic. So I think we could get a lot smarter with the way we use reference ranges.
That's great. Thank you very much, Owen. So we've got 2 minutes to go. I think we will finish the questions. Obviously, we will have a look at those, and if there is any other themes that we can certainly collate some answers. And I'm sure the college team will help us to provide that on the website as well. If you do have any other questions or want to get in touch with the couple of questions that Owen has posed for you to think about, there is the email of meetings@rcpath.org, which has been put in the chat now. So I think I will like to finish up saying thank you to Owen for your wonderful presentation. I know a little bit more about AI now. I'm sure I should have known that beforehand. And thank you to Kristen and Carla, who've been supporting us. And thank you to all of you who have attended. As mentioned earlier, this webinar was recorded, so you can go back and watch it again, or reach out, tell your friends, and they can go and watch it and learn about AI. So thank you very much.
Thank you for me as well. Thank you.